So I think we know that acute myocardial infarction, cardiogenic shock still remains one of the big challenges in cardiology. And we also know that the survival rates will vary from the time of putting the patient to the mechanical circulatory support from the time of diagnosis. And just from 1.25 hours to if you cross 4 hours, the mortality, the survival decreases to 26%. So one has to act very fast. And now these are the definitions, of SKY shock classification, A, B, C, D, E. It is modified a little bit by the the cardiogenic shock working group. And I don't want to go into the details, but the most important thing is that the stage B is the most important stage where you have to be very active to take action immediately. Like stage A, B is where there are already some signs of decompensation and you have to work very fast. So if from stage B, if progression is 4 out of 5 patients will go to stage D or E, and if you go from D to E, there's a 90% mortality. So that only means your action should be immediate rather than thinking and delaying the process. And now there is a shock. This trial showed that in cardiogenic shock, acute myocardial infarction, the mortality is there is a 12.5% reduction in mortality. Number needed to treat these just 8 patients to survive, to make one life survive. So this is a clear-cut data that the Impella, the immediate mechanical circulatory support, is useful in these patients. So identify early, stabilize early, revascularization as per guidelines, and systemic use of right heart catheterization is becoming very important. And then you see whether there's a myocardial recovery, then you can wean off the support. If there's no recovery, then you have to take a decision whether we can put a LVAD or this patient can be done a cardiac transplantation in these patients. So there's a national CSC algorithm, rapid identification of the cardiogenic shock, cath lab activation, femoral access, acute myocardial confirmed. Then you take these patients to the cath lab, and then there are new things. Put on the mechanical circulatory support. I'm talking about Impella, PCI, right heart cath. If the CPO, the cardiac power output, is less than 0.6, then to calculate we call it the PAPI, that's pulmonary artery pulsatility index. And if it is less than 0.9, and it means possibly RB failure, consider RB support. If it is more than 0.9, RB is normal, consider LV support. And if the cardiac output, power output is more than 0.6 and PAPI is more than 0.9, continue to titrate the decreased pressure and anatropes in this situation. So this is the same thing. If you have a cardiogenic shock, isolated LV failure, rule out hypovolemia, volume resuscitation. LV is dominant, that means the RA pressure less than 15, capillary pressure more than 18, and PAPI is more than 0.9, then you need Impella CP or Impella to 5.5. Isolated RB failure, where dominant problem in the RA pressure more than 15, the capillary pressure is less than 18, and RA capillary pressure ratio is more than 0.63, then inotrope, vasodilators or right heart Impella is the way to go. When you diagnose biventricular failure, you have to implant Impella. That means you need RV as well as LV support. You have a patient with cardiac arrest. If you return the circulation, then this is the algorithm. But if there's you have tried 30 minutes, then you need to put this patient into the VA ECMO. And active unloading has to be done with Impella, even if you put the patient on ECMO. So this is called, basically ECPella, where you put Impella 5.5 plus ECMO in these patients. So these are the CP, Impella CP 3.5. This can give you cardiac output 3.5 to 3.7. But now we have Impella, which can give you cardiac output 5.5 per liter. So there's not, I don't want to go into the details, but you know, the CP 14 French, you know, diameter for the entry, this needs 18 French, outer is 21. Usually the CP Impella you can use for about a week, but the 5.51 you can use up to even 1 month, 29 days is the recommendation. And if you think you need for a longer time, then there is a possibility of entering through the axilla rather than through the femoral route in these patients. So PA catheter is recommended for continuous monitoring these patients, right heart function, preload, afterload, left heart function, PA catheter, and complete hemodynamics. So you have to do a proactive management, and complications like bleeding, sepsis, limb ischemia, stroke, and you know, you can download, there are you know, applications available. You can light of the checklist on these patients. So basically, Impella means insertion site. The M means the mean arterial goal. It's more than 60 millimeters of mercury. Hemodynamics, you have to keep under control. Position, preload and RB function by echo. E means end organ perfusion, escalation and de-escalation. L means lactate level. Very important, you have to monitor the lactate levels. And second L means that you have to have alarms, respond quickly to all these response whenever you have patient is on anticoagulation rate. So it is something which is highly intensive therapy, and you have to be very active to get some positive results. So a lot of mortality predictors. So I don't want to go again into there are figures available, whether you early escalation or you consider escalation close observation, when you want to wean, when you want to you know, wean the pressure, when you want to wean the mechanical circulatory support in these patients. I think there are a lot of these guidelines are available in the literature. I don't think we can discuss all this in this. So correct placement of the Impella is very important. So it should be stable, not rocking. And when you enter the LV, see that you are not going to the papillary muscle, the chordae tendineae. It should be free. And usually you would like to keep the inlet in the middle of the cavity, or almost like a 3.5 or centimeter or 5 centimeter for Impella, and 5.5 in the Smart Assist. Inlet should be free of mitral valve structures, outlet positioned well above the aortic valve, and it should be unobstructed to have a proper function. So identification of escalation needs. Increasing use of inotropes is the lactate worsening. But about the cardiac power output, you know, less than 0.6, certainly less than 0.8 with the inotropes. Also, these are patients that, you know, borderline, a PAPI less than 1, decreased urinary output, and low systemic saturation. If there is one, yes, for one or more, then you have to advocate the escalation of therapy. The thing to note is that every hour delay in the escalation was associated with almost 10% increase in the risk of cardiac death in patients. So again and again, I want to emphasize that take action in time. So 90-minute significant decrease in survival. If it's door to the mechanical circulatory support. If you put in a Impella within 90 minutes, then there is definitely evidence that it will improve the mortality. And there's a double the chance likelihood of 30-day survival for patients who were treated according to the SOPs given by the European Society of improved chances of survival, best practice protocols in cardiogenic shock. If you follow those best practices, 71 to 80% is survival in these patients. So hemodynamic effect of the Impella support, outflow, increased cardiac power, mean arterial pressure will improve, and inflow, it will decrease the LV EDP, it will decrease the end diastolic volume, so it will decrease the wall tension, microvascular resistance, myocardial perfusion, and increase the oxygen supply. Left atrial pressure, they decrease, pulmonary congestion will decrease, oxygen demand will decrease. But with the mechanical work, cardiogenic, cardioprotective signaling, and reperfusion injury is decreased by Impella. And let's talk about the ECMO. ECMO flow will increase, cardiac power will increase, the mean arterial pressure will improve, but what are the downsides? the LV EDP increases, the LV diastolic volume increases, there is increased wall tension, microvascular resistance is increasing, myocardial perfusion will decrease and oxygen supply will decrease. Left atrial pressure again it will increase, pulmonary congestion will increase, oxygen demand of the heart will increase. So mechanical work, cardioprotective signaling will go down and reperfusion injury will be more. So this is the VA ECMO, which is one of the other modality of mechanical circulatory support. So I think we can leave this slide. Consider escalation from Impella CP to Smart Assist 5.5 if you have unable to gain the inotropes and vasopressure or lactate is more than 2 millimoles per liter. And then there are some other defined criteria that when to escalate from Impella CP to Impella 5.5. RV failure, RV assessment is very, very important. There are clinical signs. You have to look in the hemodynamics, look at the echocardiography, and LVAD, specific sign have to be also considered in mind. So then there are defined criteria of formulas to assess the RV function. There are a lot of formulas which are all available in the literature. The role of echocardiography from time to time again is very important to understand the hemodynamics, the IVC volume, the RV dysfunction, which will make you much more wise how to deal with it. Now Impella with ECMO registry, there was a Impella trial. So this was a trial on daily ramp trial on echo, decrease ECMO flow and increase Impella flow. If a patient is stable with Impella alone, patient is on both, but you downgrade the ECMO and see if the patient is stable on alone, then wean and remove the ECMO. Continue with the LV support with Impella, but if flows are not adequate on Impella alone, then continue Impella plus ECMO support both in these patients. Consider changing to axillary ambulation if you think you require the support for many more days. So these are the ACC, American Heart Association 2025 guideline. So Impella is 2A, and I want to also emphasize that as far as the ECMO is concerned, it's a 3. That means there's no benefit of ECMO alone using patient with the acute cardiogenic shock. So I think it is clear that the default line of action in cardiogenic shock should be Impella rather than the ECMO. So this is very clear, and I also want to tell you that we will have our annual conference on 27th and 28th February. We do Indian Complex Arrhythmia Summit and also the Advanced Cardiovascular Therapeutics Conference in New Delhi, and I will welcome all of you to participate. Thank you very much.